I am going to be presenting on the other side of things. So in Guatemala. So my name's Ethan. I'm a fourth year KCU student. My interests are in global health and global mental health. And so this is research that I did alongside Katie as part of the KCU Global Health track. So as you saw, Katie presented on the Kenya side of things, and then I'm going to be presenting on the data collected in Guatemala. And we try to focus on some of different aspects of things to vary the presentations a little bit. But this is our team, so thank you to Dr. Desai and Dr. Cooley, who helped us develop this study and were our co-PIs. And then also a special thank you to Dr. Seegers and to Cecilia Ponce, who's a social worker here in Kansas City, who helped with the translation of our survey into Spanish. Now, the agenda for today, I'm going to be going over some background research and available information on depression in Guatemala. And the methods and research are going to be going over perceptions of depression and treatment modalities. And then gonna end our discussion also with talking about some ethical considerations for global health work. Now, looking at the global burden of depression, depressive disorders are a major worldwide issue. So particularly in the Americas, and so that's including the US, Central, South America, Canada. Depression is the #1 contributor of years lost to disability. And this is data available from the WHO in 2015. Now, if we tease that statistic out a little bit more, comparing Guatemala to the United States, we see that actually depression is more of a contributor to years lost to disability in the US compared to Guatemala. I think this is an important thing to recognize, that the US, although it's a high-income country, we're greatly affected by depression here. And we're going to talk about this a little bit more in the discussion of ethical considerations for global health work. I do want to say, though, that some things that could be affecting this is underreporting in Guatemala due to lack of resources for data collection on who is and isn't experiencing depression. But also, these are the statistics that we have from the WHO right now, and so it's an important thing to consider and acknowledge as we research this topic. Same thing when we're looking at suicide rates. There's higher suicide rates in the US per 100,000 than there are in Guatemala. So our view that these middle low-income countries are enduring so much more suffering than us, is something that we should step back and challenge when we're faced with statistics like this. Questions how we're looking at individuals in low-income countries. Now, using that biopsychosocial model of looking at depression, some of the factors that aren't necessarily unique to Guatemala, but are very predominant in Guatemala, some of the predisposing factors would be things like low socioeconomic status, domestic violence, childhood physical and sexual abuse, and gang violence. And then looking at some of those precipitating factors that might precipitate an acute depressive episode would be that lack of social support, substance misuse, ongoing social unrest and violence in Guatemala, and even more recent events such as like COVID-19, that caused isolation. And there's been some more recent studies done in Guatemala that showed that there was an increase in domestic violence during the COVID lockdowns. Those are all things that could precipitate depressive episode. And looking at perpetuating factors, that's a lot of it is the same things that could, cause ongoing depressive symptoms of lacking those psychosocial supports and resources in the community, physical illness, substance misuse, and social stigma is a big part there. Now looking at the WHO data on access to mental health resources, Guatemala only has 0.5 psychiatrists for every 100,000 inhabitants. And for comparison, the US has 10.5 psychiatrists per every 100,000 inhabitants. And this is 2016 data. And so also I saw one statistic that was saying that there's only 5 psychiatrists in the whole country serving rural areas. So the psychiatrists that are available are more condensed to those urban areas. Now, with such a lack of mental health resources, it's important that we that we assess the mental health needs and perceptions of the population. So if there's more resources that are made available for mental health, we can do so strategically. And so when we're looking at barriers to treatment, some of those things are like limited community facilities for mental health care. There's one study looking at mental health training for primary care physicians in Guatemala, and it was really lacking in their curriculum. There's a lack of knowledge and false beliefs around mental health, stigma. And then, some of these barriers are, there's a goal of trying to address those through short-term medical missions, but those are certainly not perfect and can have, a lot of problems, things like language barriers, lack of trust of non-native clinicians, and, maybe the biggest issue, lack of continuity of care. And there's also been some efforts to train non-mental health professionals to deal with suicide in Guatemala, but despite those studies being done, the effectiveness of this is really unknown at this point. Now, so these are some of the questions that we're going to be looking at in this study. I kind of focused on different ones than Katie to mix things up for the sake of this presentation, but I'm going to address each of these questions basically as they come up, but we're looking mainly at perceptions of depression and perception of treatment modalities for depression. Now, starting with our study, going into the methods, Katie went into a lot of detail on how we developed this study. So I encourage you, if you're watching this maybe as like a recording afterwards, you can go back also and watch that presentation on depression in Kenya that outlines nicely how we developed this study. But for a quick, summary of what we did, the KCU, this data was collected during one of the KCU Guatemala Global Health trips in February of this year. This is data collected from 6 different rural communities surrounding Antigua, Guatemala. Participants included clinic patients, people accompanying family members at the clinic, local staff. Really, we included anyone who was Guatemalan and over the age of 18 years old who wanted to participate. And, and here's our survey breakdown. It was 49 questions in total. Yes, 14 questions collecting demographic information, and medical and psychiatric history, 9 questions where they took a PHQ-9 that was validated in Spanish. And then we had 3 questions for vignette 1 and again, vignette 1 was that affective or emotional symptoms of depression describing an individual that had a PHQ-9 score of 14. And then the second vignette was also describing an individual depression symptoms, but more of like the physical somatic symptoms of depression, but they also had a PHQ-9 score of 14. And then we had 20 questions at the end that were specifically asking about, in reference to an individual who had a PHQ-9 score of 27, which is the highest it can be on the PHQ-9. And so I'm not going to go through all the different demographic data, but basically what I want to draw our attention to is with a sample size of 45. Again, it's a pretty small sample size. And it was very poorly distributed. We only had 8 male participants and 37 female participants. And I also want to draw attention to our PHQ-9, like I had mentioned when we were discussing Katie's presentation. We can't diagnose patients with major depression based on a PHQ-9 score. It's used as a screening tool, and in order to diagnose someone with like major depression, for example, you need to make sure it's not due to another medical condition, to substance use, and you also need to make sure that the symptoms that they're experiencing are causing impairment, which isn't necessarily something that we can get from the PHQ-9. So that's a limitation of our study that we'll talk a little bit more about in the discussion. Now, looking at our demographic data and the utilization of mental health resources, 22% indicated seeing a mental health professional before. And that's higher than what we saw in the literature. In the literature that I was reading, it was anywhere between like 1% and 5% in Guatemala. And so it's important to know that this specific population isn't necessarily representative of the Guatemalan population as a whole. These are individuals that are actively seeking out their treatment by being at this clinic. So they might also be, better at seeking out healthcare for their mental health. Now, when we look at those that have utilized um, basically mental health resources, seeing a psychiatrist, psychologist, or another person to treat their mental illness, looking at that based on if they had a PHQ-9 score of 10 or greater versus 9 or less. So I divided it a little bit different than Katie did in the way that she presented her data. But looking at the individuals who might have moderate, moderately severe, or severe depression, only about 33% of them had ever seen a psychiatrist, psychologist, or another person to treat their mental health before. Now going into the perceptions of depression, we, again, vignette 1 was describing an individual, that emphasized more the affective or the emotional symptoms of depression. And vignette 2, was an individual with more of the somatic symptoms of depression. And we saw that after reading that the emotional vignette, 84% of patients recognize this as depression. And then when they read the physical vignette, only 73% of these patients recognize this as depression. So there's about 11% difference in recognizing this as depression. So they're more likely to identify it as depression if it includes the emotional symptoms, is what we found in this population. But then when we ask them if this is a medical problem, then 53% of patients from the affective vignette or emotional vignette, 53% of patients recognize this as a medical problem, and 64% of patients recognize this as a medical problem. So again, there's a 11% difference, but in the opposite direction. They're more likely to identify depression as a medical problem if the depression includes somatic symptoms. So, what we're finding is that there might be some sort of disconnect, that depression is a medical issue based on this finding. So moving on to our next set of data, basically we wanted to assess the ability to recognize the described individuals in the vignette as having depression based on a PHQ-9 score. Those with a higher PHQ-9 score were more able to recognize both affective and somatic symptoms of depression. But this, you could see here, it's higher in those that had more able to recognize it in individuals that had a higher PHQ-9 score, but these aren't statistically significant results. We ran a chi-square test, and so we really can't make any claims as to that. Now, we looked at other variables as well, basically patient sex and their ability to identify depression symptoms. But again, our p-values were not significant, so we can't make any claims there, but we just wanted to show that we did look at those variables. And again, these are other variables that we looked at: patient sex and the perception that the patient is weak-willed, patient sex and the perception that it's acceptable to feel this way, and patient generation, basically, and the perception that it's acceptable to feel this way. But again, not significant results there. So not spending too much time on that. But the one that I do want to look at a little bit greater detail is this patient sex and the perception that it's acceptable to feel this way. Because we look here and basically, although it's not significant, basically, it's in reference again to reading a vignette that described an individual with a PHQ-9 score of 27. And for males, we had 75% of them say that it was unacceptable to feel this way. And only about 30% of women said that it was unacceptable to feel this way. So this would be a good question to look at in future studies. But right now we can't claim it as any significance because we have a p-value of 0.158. Now, when we look at perceptions of depression and basically the influence of religion and spirituality, I want to emphasize here that this is a very religious population. There's only 9% of individuals within this population that either said they were not religious or of a non-Protestant, evangelical, or Catholic religion. And so when asked about the individual that had a PHQ-9 score of 27, 49% believed that there would be a spiritual or religious reason for this person feeling this way. And 78% here said that they believe this person will likely get better if they pray more, with only one person disagreeing with this statement. So, and we imagine these results would be different in the US populations. And so this could be important insight for providing that culturally informed care. Now looking more specifically at the perception of treatment modalities for depression, basically here we asked individuals if the doctor prayed with this person, the person would likely either trust the doctor more, and that was 73% of responses. It would make no difference, 11% of responses. 16% of responses said they were not sure, but no one from this population said that they would trust their doctor less if their doctor were to pray with them. So again, interesting results. We'll talk a little bit more about in the discussion. And when it comes to treatment of depression and clinician preference, we wanted to see if there was a preference for basically doctor-patient sex congruence, in that like two females prefer a female provider or female clinician, and males preferring a male clinician. And we had 25% say that they preferred a doctor of the same sex, but overwhelmingly 73% of people said that they were fine with a doctor of either sex. And we looked at this too, breaking it down between males and females, seeing if there's any difference there. It does look like from our data, there's a higher percentage of females that preferred to meet with a female provider than males wanting to meet with a male provider. But again, these aren't significant results, so we really can't make any claims. The majority of people here said that they were fine with meeting with a doctor of either sex. And then we also looked at the preference for patient-doctor sex congruence by religion as well, but I'm not going to spend much time on that. We had an insignificant p-value there as well. Now, when we're looking at other modality preferences, and again, this is in response to the patient's read a vignette about an individual with a PHQ-9 of 27. And when asked if weekly meetings to talk about feelings would be helpful, 78% believe that, or sorry, 76% believe that that would be helpful. The 78% is from those that believed exercise would be helpful. And then overall, it seemed like patients were a bit less receptive to medications, both plant-based medicines and herbal remedies, and medicines from the pharmacy. We had 58 saying that they believe plant-based medicines to be effective, and then 53.3% believing pharmaceutical medicines to be effective. So, this can help inform us of what treatments to lean into, and which treatments to provide some education on. Most patients that didn't respond yes to whether they believed one would be helpful said that they were unsure, but they didn't, there was a smaller amount that just said no. So it seems like there is some room for education on these topics within this population. Now, when we look at treatment of depression and preference for therapeutic setting, most individuals, they preferred individual therapy as opposed to group therapy. But we had a good 22% as well saying that they didn't have preference for one over the other. And when we break that down by generation, it seems like there's more uncertainty within Gen Z, but also it seems like Gen Z has a bigger proportion that believe both individual and group would be preferred by them. Millennials largely preferring individual therapy, and then Gen X, they had one preference over the other, group or individual, but not as many being okay with both. And I'll say that the p-value here is approaching something more significant, but it's still not a significant p-value. So again, can't make any claims there. And then we also break down preference for pharmaceutical medications by generation. Gen X appeared, to perceive medications for depression to actually be effective when compared to these other groups that were more unsure. But again, our sample size was so small, and our Gen X sample size was very small at only 5 people. So again, can't make any significant claims here because our p-value is 0.086. Now, starting our discussion on the results, just want to address the limitations up front. These to us seem to be the most prominent. We had a really small sample size, again, of 45 individuals, poor demographic distribution, both by sex and by generation. Our survey length was really long. So, that limited, people's willingness to participate. It also appealed more to people with higher literacy, because although we offered translators, or people that can read the study to them, it wasn't, no one took us up on that offer. And then there's those within this population, they're actively pursuing medical treatment. And so there's a selection, bias towards that group as well. And then, as I had said earlier, that PHQ-9 data, we're unable to get a clear diagnosis and history of depression, based just on the PHQ-9. Now, looking at each of these questions individually, starting with the perceptions of depression, is there a difference in the perception of depression depending on whether that depression is characterized by somatic versus more affective symptoms of depression? And so we saw for the somatic symptoms, more said that the individual had a medical problem when presented with those physical symptoms, but less identified that problem as being depression. And then when we looked at the affective symptom responses to after them reading that description, more said that that person had depression, but they were less likely to identify that as a medical problem. And our next question that we were wanting to address is depression perceived to be a medical problem or a separate issue? We did see that there was a discrepancy in identifying depression as a medical issue. And then that third question, is there a demographic influence, sex, generation, spirituality on perception of depression? And the short answer is no. We didn't have any statistically significant results in order to make that claim. But we imagine that our small sample size greatly influenced that. And we'd be curious to see if there could be a significant result with a larger sample size. And then looking at that perception of treatment modalities for depression, what are the preferred treatment modalities for depression within rural Guatemalan communities? It did seem like patients preferred treatments that had that more holistic approach, such as exercise and therapy. Many saying that they were unsure of the psychopharmacology for intervention. And then our last question, is there demographic influence basically on the treatment modality preference? And again, short answer is no, because we didn't have anything statistically significant there. And so our conclusion, again, not having any statistically significant results as far as looking at the relationship between demographic variables and perceptions. We do believe that the frequency data that we collected, though, on modality preference can inform some culturally competent care for future KCU Global medicine trips that go specifically to these populations. We believe that provides us, the ability to educate this population on the medical basis for depression. Education on effective treatments for depression could be beneficial, and encouraging exercise and therapy, because that does seem like something that this population is already open to, and reminds us to ask about spiritual beliefs. And given that there does seem to be such a opinion that praying would be beneficial, amongst this group. This group might be a group that would benefit from chaplain services, if that's something that could be made available. And when it comes to future avenues of research, repeating this with a more concise survey and a larger sample size, I think could be helpful. Also assessing that effectiveness on education on depression, and then assessing the utilization of different treatment modalities. Now, I just want to finish up these last couple of slides, just talking about some ethical considerations for global mental health research. A lot of these things were brought to my attention by a talk that I watched from Dr. Sanya, who's a resident at Yale. And so she brought a lot of these things to my attention just from watching like an online video where she discussed these things. But there was a study published, The Inequities of Mental Health Research Funding, that identified that 98.6% of mental health research is funded by high-income countries. So per capita per year investment in mental health research in the US is 1,000 times greater than in low and middle income countries. So from this, we're gathering global mental health research is important. There's a very small percentage of global mental health research that is allocated to understanding mental health within low and middle income countries. But we also need to be aware that most of the data that we do have from studies in low and middle income countries on mental health are funded by high income countries and not the host countries. And so, being aware of that bias that might exist there. Now, circling back what we saw in the intro, where depression was a big contributor to percentage of years lost to disability in the US versus Guatemala, the same trend is true in comparing all high income countries to low middle income countries for all mental disorders, combining that, not just looking at depression. And there could be multiple reasons for this. That statistic could be pretty much accurate. It could also be that there's an underdiagnosis in low-income countries. There also could be demographic factors, such as low-income countries having a younger population where mental health disorders are less common. But all the same, I think it's important that we recognize that a lot of Americans say that the U.S. stands above all other countries in the world, or is one of the greatest countries, along with some others. Pew Research, found that 72% of Americans believe that, and I think we need to see, is this a view that's pervasive in the global mental health field? So it's still important to be learning about the mental health needs in these low and middle income countries and expand access to care for those individuals that need, mental health services. But we should also be careful about the assumptions that we're making about low income countries and mental health, and be careful that we're not perpetuating this harmful history of, colonization, where we go to these other countries on short-term medical missions, conducting research from a vantage point that we need to change their culture to improve their mental health, because some of these countries might be doing better than us in the US in certain regards to mental health. So just two more slides, almost done. There's some global health research, is carried out in the conjunction with short-term medical missions. So it's important to address some of the shortcomings of short-term medical missions. Here's a study name called Perception of Short-Term Medical Programs in the Dominican Republic. And some of the shortcomings that individuals from those countries were able to address were, the language barriers that exist in work conducted by short-term medical missions, undermining of local knowledge, students working outside the scope of practice, and a lack of collaboration with existing medical personnel in the community of focus. And so there have been few guidelines that have been developed for short-term medical missions, but this is one that came out a couple years ago that includes perspectives from host countries. Basically, they created checklists both for the host and sending countries, and then collected perceptions on the checklist as far as usefulness from the host countries. And I'm not going to read through, all of the different things, but one thing that's really emphasized in this checklist is the importance of long-term partnerships and doing needs assessments and really working towards those long-term goals, and trying to reach goals that are self-sustainable for the country, that they can carry out on their own, and not being dependent on providers from high-income countries. And last thing is, there's even fewer guidelines for global health research specifically. This is a checklist that I found that was published in 2018. And as of now, there aren't any other checklists that have been developed, but it touches on a lot of the similar topics for global health research. It's important to understand how the local culture and community influences your study. And also there's that emphasis on establishing local partners. So this is all things that KCU aims to do with our short-term, medical mission trips. We are partnering with NGOs and local providers, and really trying to connect patients with that long-term care. And so I do think that is something that in some ways we do really well, but there's always, ways to improve upon it. So I just wanted to end the talk with talking about those those considerations for those of us that engage in medical mission work and in research in those environments as well. So that's all, and those are my references.